everyone. How's it going? Okay, good.
Morning here.
Hey. Hey, the good thing about seeing your first part exam is that lockdown doesn't mean much. So, yeah. Good time to be in Melbourne. I managed to escape Melbourne with 12 hours to spare. I'm now in Western Australia. I think I might just stay here. Hey, so let's get started. So got a bit less time than usual, but this is a short segment and then we can do some SAQs and just practice that kind of stuff there. So respiratory third session. Just to start with, let's kick it off just explaining this diagram. I'll just kind of go down the list as I usually do. and just to clarify as well, like I remember the examiners just showing some pretty, basic-ish diagrams and just wanting you to explain the most basic stuff about something. Like it was like, they just had to get the initial marks out without getting into too much advanced stuff. So
it looks like there's kind of three separate diagrams here. So it's kind of demonstrating different kind of VQ matching. So on diagram B, that shows some kind of blockage to alveolar ventilation. So it looks as if the partial pressures there are a partial pressure of oxygen of 40 and a partial pressure of carbon dioxide of 45, and there is no limitation to blood flow. So there's a decreased VQ ratio trending towards 0.
Yep. What's it called?
Then diagram A shows.
What is with diagram B? What is that then? What would you call that? Everything you said was right. What would you call that? With a VQ ratio of 0.
I guess like dead space.
No, the other one.
Oh, sorry. It's shunting. Sorry, it's blockage to ventilation. So blood's being shunted.
Exactly. The funny thing is, I know that that's shunt, and every year, so many, including myself, will say one of these things wrong, just because it's just one of those concepts. I remember the person giving the respiratory shoots when I was going through training confused it as we were talking about it. So everyone's going to make potentially say that wrong, but that's fine. That's good. It is dead space. Sorry, it is shunt. There, I've done it again. It is shunt. What are those numbers? O2 and CO2. What does that look like?
So that looks like your venous, mixed venous blood partial pressures.
Fantastic. So when Wes talks about this diagram, they say that the dead space gas composition in that alveoli, in the dead space, in the shunted alveoli, tends towards mixed venous, the mixed venous gas profile. Keep going.
Then in the middle you've got diagram A, so that shows no obstruction to ventilation or perfusion, and your partial pressure of oxygen is 100 and partial pressure of carbon dioxide is 40. And then you've got as I said, normal flow of blood as well, so that's just normal alveolar ventilation taking place.
Fantastic.
With no VQ mismatch. And then diagram C shows some kind of obstruction to flow, but unobstructed ventilation. So the partial pressure of oxygen is kind of the same as what you'd expect in the atmosphere at the mouth.
Fantastic.
And there's no exchange of gases taking place. So your carbon dioxide level is negligible and your VQ ratio is trending towards infinity.
And what's that an example
of? So that is an example of dead space.
Yeah, that's right. It's an example of dead space. Good. Next person along, Brian Yip, if you're around. Hey Brian, just give me some examples of dead space.
Also, a classic example of dead space ventilation would be a formation. Oh, actually, I think we've covered this the last time.
But you're right. Technically,
Sorry?
Technically, that is dead space ventilation, although it creates lots of other problems and changes, but it's complex.
And I think you talked about how it may potentially not cause hypoxemia or something like that. All right, yeah. So pulmonary embolus, otherwise, it's also known as West Zone 1 ventilation. So that you might find an example of dead space ventilation in positive pressure ventilation.
Yep. And one other thing that happens pretty commonly in
I guess profound shock states where there's sort of reduced cardiac output.
Yeah, exactly. And so it seems dead space, when I used to think about it, was often it's kind of like lung cause and things, but even simple things like hypotension can cause this as well. So that's good. And just to clarify then, so the pulmonary embolism, I remember thinking, why is it that pulmonary embolism causes hypoxemia? And looking it up, there's, pulmonary embolism is a complex disease. There's so much going on when you get that clot in a vessel. So you not only have blocking of an alveolus that can cause dead space, but you now get all of that blood shunted to different parts of the lung, changing their VQ ratio, so that contributes to venous admixture, and the inflammation from this pathology can cause shunt as well. Catherine Ricard, tell me some causes of shunt.
Right, now I'm on mute.
Yeah, nice.
So shunt can be categorized as physiological or pathological. So physiological causes of shunt would be from the coronary circulation going into the thespian veins, and then also would be the bronchial circulation.
The Thespian veins?
Which has its oxygen taken and then returns to the left side of the heart without being oxygenated, obviously. So pathological causes would be, you can have intracardiac causes, so any cause that really, whether it's a PFO, whether it's between the great vessels, that essentially causes venous blood to bypass oxygenation and return to the left side of the heart. They're the ones that I can remember off the top of my head. I know that there are others.
That's good. And any lung causes?
So pathological lung causes.
Yeah.
So P.
Yeah, as we mentioned that, I mean, it's like it causes dead space and shunt.
Yeah. Like VQ mismatch as well. So as it approaches towards infinity.
Yeah, that's right. What are some causes that would literally block off an alveolus?
So I think that's West Zone 4. So that would be lobar collapse, like consolidation.
Yeah, look,
at the base of the lungs.
I wouldn't say it's West Zone 4. We'll get into that to clarify it. But yeah, anything that causes a collapse of that. So atelectasis would be a cause of shunt. And when I think of this diagram here, I just think, what else could plug that alveolus, the entry of oxygen and ventilation to that alveolus, and really anything, aspiration or sputum, bronchospasm,
pulmonary edema,
exactly,
pneumonia.
Yeah, good. Let's keep moving. So this was it.
Can I just ask a good question, if that's okay? Sorry, it's Luke.
Yeah, of course.
When we're talking about hypoxemia, we always stress that shunt is different from VQ mismatch. But then when classifying the causes of the types of shunt, we start talking about VQ mismatch. And I'm just trying to reconcile in my mind these being both separate entities, but also being, discussed in the same breath. I know that they're part of a spectrum, and I know that shunt's just that, VQ equals 0 sort of end of that spectrum.
Yes.
But, how when you want to say in hypoxemia, causes of hypoxia, that shunt and VQ mismatch are two separate things, but when talking about types of shunt, you include VQ mismatch under that. I struggle to reconcile that. What are your thoughts?
I suspect that if I asked you the question, you'd answer it absolutely fine. So if I said, what are the causes of shunt? I think you could list the causes without even mention a VQ mismatch. If, however, I asked you the question, what kind of, how does asthma or bronchospasm or pulmonary edema or PE cause hypoxemia, you might say that, well, it can cause a spectrum of problems. For example, any of these pathologies can cause changing VQ ratios, which will contribute to venous admixture. And at the worst case, there will, something like severe consolidation or lung collapse will cause absolute shunt in that situation. That's how I talk about it, because the human body is often a spectrum of problems, and pulmonary embolism, asthma, APO, all of these are really great examples of it. But yeah, I think the reason I don't find it a problem, if someone asks me shunt, I don't mention VQ mismatch. If someone asks me what does this cause, then I'll go, okay, well, it causes all of these things. Let's talk about it now.
Okay.
Yeah, hope that answers your question.
Yeah.
Can I ask another follow-up later, if that's all right?
Absolutely.
Just something I've always sort of assumed but never actually checked with anyone who's well educated in the area. When we discuss VQ mismatch, are we always explicitly referring to VQ ratios less than 1? Because the term mismatch doesn't necessarily imply that, but pretty much every time we talk about mismatch, we're discussing situations where that is the case. And if a VQ ratio was greater than 1, I can argue that the ventilation and perfusion are not matched, but we would not classically call that VQ mismatch. And my understanding would be it would not cause hypoxemia.
Yeah, actually, so ask that question again, like an examiner is going to ask you it.
I guess I would say, what is VQ mismatch?
Yeah, and I think you can answer that, because the problem is I don't see that as a problematic question, because we know that the average VQ matching of the lung is 0.8, so you could consider that as normal but suboptimal, because maybe it should be 1. And I think it's more just an observation of what occurs in the lung, that you're never going to get a lung that doesn't have VQ mismatch. It's virtually impossible. There's too much variability due to gravity and lung physiology and embryology. That it's almost like there's no such thing except in artificial modeling of perfect VQ matching. So I feel like there's never going to be that situation where you have to comment on anything but abnormal VQ mismatch, because it doesn't occur.
Do you mind if I ask it in a different way?
Yeah,
so
absolutely.
when we refer to the apex of the lung, which has a relatively higher ventilation compared to its perfusion, so it has a VQ ratio greater than 1, if you were asked if the apex of the lung contributes to either VQ mismatch or venous admixture, what would be your response be?
Yeah, I'd say, so first of all, because I'm not a respiratory physiologist, what I'd be saying is kind of just talking out of, my answer would be as good as anyone else's in the spectrum of what an answer is, okay? So just to give you that first. I would literally say the ventilation ratio is increased with more ventilation than matching, so there is some VQ mismatch in that sense. This contributes a higher PO2, but because it's at the apex of the lung, it contributes less volume of blood to the system. This system, the fact that the lung has multiple areas of VQ matching, means that while this doesn't contribute hypoxemia, it does represent the inherent physiology of the lung being suboptimal and having multiple, many different VQ ratios. I think that's how I talk about it.
Yeah, no, that actually caused a little light bulb to go in my head. So thank you. That's great.
Oh, good. I'm glad. That's good. Yeah, let's keep going. But yeah, these questions are really good. I mean, because I'm not thinking about this in the way you guys are thinking about it anymore. So I'm really glad that you're asking these questions. I just put this graph in here because let's get someone again. I think this exam. It was interesting when I talk to people who've done the exam. They're often quite frustrated that the examiners will ask them something and they won't really let them move on. They want these absolute basic points first. So it's one of those sad things. I felt like, I remember knowing so much about propofol, and this one examiner just wanted me to sit down and literally talk about propofol. Okay, so what happens? Oh, it goes into the vein. And I started talking about all this complex stuff. Oh, no, whoa, slow down. What happens to the propofol? Yeah, it goes into the vein, yep. And then where does it go? Okay, it's in the central compartment. Then where does it go? It's the fact that I think they need you to say the most basic things to get the marks and move on. So with that said, George, can you just describe for us these two graphs from West?
Yep. So for these two graphs, it's essentially correlating the difference between a high maximal VQ and a VQ of 0 to the different anatomical areas in the kind of cardiopulmonary system that you would find those values. So I guess essentially the graph on the left is a repeat of the one from previous, where you have true shunt on the left side with a low PO2 and essentially mixed venous blood going into and then out of the alveolus, and then you have dead space ventilation on the right, which is, and you can see the small symbols on the left. It's kind of like I guess that's a blood vessel or something, and then on the right, at the very bottom near 150 on the left graph, it's a little kind of conducting airway. So that's essentially what you would find if you sampled conducting airway. And so moving on to the right graph, that's essentially what you see. You find the in true shunt, it's essentially akin to sampling the the right heart, and with an infinite VQ, you're essentially sampling conducting airway, and then because of the gravitational effects on the lung, the distribution.
Sorry, you keep going.
The distribution of VQ is essentially organized where the apex of the lung is more akin to conducting airway, and the base is more akin to the mixed venous blood, and mainly because of the
Hey George, I'm going to stop you there. I feel like you've said a lot of information, but I reckon you can get through quicker. If you were to just say 2 sentences to describe this, because I guess I want to try and make you as sharp as possible with the way you're practicing this. 2 sentences, and don't make them long. Describe those graphs, or describe the right graph.
Right. So it's okay.
So I'm just going to put it up again.
Yeah. So it's a graph that demonstrates the effect of gravity on VQ ratios within the lung. And
it's harder when you got 2 sentences, right?
Yeah.
I would actually go...
And the proportional difference it has on both PCO2 and PO2.
Okay, good. So the way I'd kind of say this is a graph showing all the different VQ, VQ matching of each lung unit, all the lung units possible in the lung, PO2 on the x-axis, CO2 on the y-axis, and it shows that at its limits, the highest VQ areas have these numbers, the lowest VQ areas have these numbers, and every other point in between represents all the different components or VQ segments of the lung. I feel like that would be, and now, so to take it to the next level, you can see all the points here roughly. Now, could you have a lung alveolus, or lung unit with it's capillary, with a VQ, with a PO2 of 7? Actually, I'm just going to get this right based on what based on what Wes has said, with a PO2 of 70 and a PCO2 of 30. And I'm just going to put that graph up again for your benefit.
Yeah.
PO2 of 70, PCO2 of 30. Whoops. That's one thing about Zoom. I wish they could do this.
Based on how those numbers sound, probably not.
Why is that?
Because certainly in this scenario, the combination of those 2 values would be unobtainable based on the degree of perfusion or ventilation that achieves, and essentially would be reliant on the VQ ratio at that point of the lung, and then the kind of diffusional properties of the gas across that certain membrane, and those values don't overlap at that point that you've described.
Yeah, and a way of saying that, so let's say PO2 of 70, PCO2 of 30, like that's that point there, right? That does not exist on this line. Every lung unit, every VQ matching segment must appear on that line. So this cannot be part of that lung.
Can I just ask another quick question?
I
know you mentioned this very briefly before, but did we decide that a PO2 of 150 is not generally achievable because of humidification?
Oh no, it is. I was actually just clarifying the maths about it because So with a humidified gas in the lung, you can get 150 if there's no CO2 going back, or if there's no extraction of oxygen. What do you think?
Well, I think that 760 minus 47 is 713 times 21. Oh, yeah, fine. Yeah, okay,
yeah, exactly.
Yeah.
Minus the R gets you to 100.
Yeah. Thanks.
no worries. Better get rid of that annotation. Whoops.
Sorry, Lahira, I just
yeah, please.
have a quick question about just building on what Mason and Luke said earlier about shunt and VQ mismatch.
Mm-hmm.
Like Wes talks about the 4 causes of hypoxemia, and this is probably just a bit of semantics, really, but
okay.
He lists shunt as one of them, and then he lists VQ inequality as another.
Correct. Yeah.
But like in my head, I always have VQ inequality, as we talked about, as a spectrum, and then shunt at one end with a VQ ratio of 0, and then dead space ventilation with a VQ ratio of infinity at the other end.
Yes.
And that's how I think of it.
Yes.
But like, would you agree with that sort of, as 4 main causes of hypoxemia? Would you?
Yeah, and I had exactly the same question that you had about this. Why don't we just call it spectrums of shunt or spectrums of VQ mismatch? And I think the whole point of this is that, I wonder if it's coming up. Were you here, Brian, when we did the venous admixture question?
Yeah, I think so.
That's right. I'm just going to ask you this because I think it's worth going through. What is venous admixture? Answer a question with a question.
Yeah. Venous admixture is the amount of blood.
That is almost the first thing that you have to say. It's a theoretical amount of blood.
Oh yeah. Okay. So venous admixture is the theoretical amount of blood that needs to be added to mixed venous blood.
And not mixed venous blood, but end capillary blood. If you think of that shunt diagram. Keep going because you're on the right track.
It needs to be added to end capillary blood to give a composition of mixed venous blood. To account for that difference between arterial and end capillary blood. So we went through this. I mean, if you look at this diagram, you've got this kind of perfect. If you were here at the end capillary in normal perfect lungs, which don't exist, then that would be, whatever your oxygenation through the lungs would perfectly combine with hemoglobin, etc., and give you a beautiful end capillary PO2. It'd be perfect. It'd be 100. Everything would be great. But this extra pathway here, this is the representation. This is the concept of venous admixture that must be added to account for this difference in the PO2. It's the whole reason that the your oxygen PO2, the PO2 drops on this HbO2 dissociation graph. So that's that. So then, why are we talking? Why are we talking about all these different
VQ matching kind of segments versus just talking about shunt and something else. Look, I think it's because shunt is just one component. When we, true shunt may be rarer than we think in certain circumstances, and just having suboptimal lungs will mean that we're actually going to get to this. If you take every single lung unit, and the fact that it has suboptimal VQ matching means that it will add a little bit of not ideally oxygenated blood. It's just, this concept is just trying to add up all of those bits. But you can see how if you take a pretty okay lung, which doesn't have any shunt, you might still have a bit of venous admixture that accounts for that difference. And so I think that's why we talk about it in those terms. Can you just describe this graph for us?
Yeah, so this is a graph that looks at the essentially VQ ratios relative to the apex versus the base and the gradient in between in the upper right lung. I guess the main thing is that towards the top of the lung, there's decreased blood flow and ventilation, but an increase in VQ ratio because the decrease in blood flow outweighs the decrease in ventilation. So on a ratio perspective, that's why you get a higher VQ ratio at the top of the lung versus the base of the lung.
Yeah, good. That was really succinct. Just talk about what the the axes of the graph. Talk about what the lines show, and I like the way you express that. Even though blood flow and ventilation decrease to the top of the lung, it's at a different rate of increase, which then accounts for this remarkable rise in your VQ ratios. That's great. Okay, I'm gonna ask this question. Actually, I'll kind of go through everyone as I'm asking these questions. So Mish, I think is next. Mish, how does the alveolus at the apex differ from the base?
So the alveolus at the apex have a higher volume and they are less compliant.
Sounds good. Keep going.
They also differ in their PaO2 and PaCO2 compared to the bases. So the apex's PaO2 is higher and the PaCO2 is lower.
Anything else?
Sorry?
Yeah, you're doing well. Anything else? Any other ways that differs?
So the VQ ratios that we talked about, so it's 3.3 at the top and about 0.6 at the bottom.
And every time I think if you're talking about CO2 changing, something else changes alongside that.
PO2 and CO2.
Okay, I'm going to ask the question again. So yeah, size is larger, compliance is less, ventilation is more, perfusion less, and then a whole bunch of gases kind of stuff. So PO2, PCO2, the pH changes as well. Respiratory exchange ratio changes, and the intrapleural pressure changes as well. Good.
Yep.
Next person along. Rudy, what do you reckon? What's the PN2 at the apex and at the base, based on those numbers that we've given you there? PO2 is 132 at the apex, and then PCO2 is 28 at the apex. What's PN2? And you can talk me through this, Rudy. What do you? How do you think you'll get to this?
Yeah, so I'm just thinking about Dalton's law, and that is the partial pressures, essentially the accumulation of the individual partial pressures. So if your partial pressures, although they're changing with the specific gases, if they end up equaling the same, nitrogen should remain the same. So I'm just doing that.
No, that's right. What would be your equation to get your PN2 pressure?
Sorry?
What would be the equation to get the pressure of nitrogen in the alveolus at the, let's say, the apex?
So I think I'd use, just knowing that 760 millimeters mercury is barometric pressure.
Yep.
And I'd calculate the partial pressures of O2 and CO2 based on the alveolar gas equation, and then just subtract that from 760.
Perfect. So did everyone get that? So let's say I've given you these pressures. Let's say in the Viva they say here's an alveolus at the apex. How does that differ to the base? And you get a whole bunch of things, and Mish went through that really well. Size, compliance, ventilation, perfusion, and then a whole bunch of gases. And then they go, okay, that's all good and well. Now tell me the PN2. And just like Rudy said, we know that, with Dalton's law, the partial pressure of each of the gases must contribute equal amounts to the whole. So 760 take away 132, take away 28 equals the pressure of nitrogen, because there's no other important gases or gases that make up any important exert any important pressure in that alveolus.
Can I just ask a question?
Yeah,
Sorry,
okay.
it's probably a silly one. But when you say that the apex is more ventilated than the base, I thought that because the compliance of the base alveoli was greater, that actually the proportional alveolar ventilation was more at the base than at the apex. But I could be just misunderstanding a key concept.
No, you're absolutely right. It is, because the compliance is more, so ventilation less. I may have been putting that in context of something, so I'll take your point and we'll get to that in the next section anyway.
Am I correct that are those numbers there just your VQ ratio as opposed to your absolute ventilation?
Yeah, I think those are VQ ratios. That's right.
Yeah, that makes more sense. Cool,
Yeah.
thank you.
No, good thing, I'll change that. Why does the pH change? Next person along, Catherine.
I'm guessing the pH changes because of our change in CO2.
That is correct. Fantastic. This was a graph out of West that, there's one examiner that literally asked the question straight out of West, and he just wanted us to talk about all of these things. And sorry, Meg, you are absolutely right. It was actually VQ. Those numbers were the actual VQ ratios, 3.3 versus 0.63. Yeah.
Thanks.
Sorry about that. Thanks for picking that up. I should just pepper these mistakes all through the thing so that people pick it up. And that's why I should say, if you can pick up 4 mistakes in this lecture, then you get a prize. That's good. CO2, and then there's your PN2 amounts, which we talked about. And then these aren't too difficult. Like if you just think of volumes, VQs, and all the gases, and what the gases lead to, like these gases lead to a pressure of nitrogen, and these gases lead to changes in pH and oxygen content. You can pretty much get an easy way of memorizing all of that. Here we go. So next person along, Dan. Why is there minimal oxygen uptake at the apex? When you think about it, it's got really high PO2 readings, right? But why is that? Oxygen in 4 liters, mils per minute, just seems so low.
Is it because you've got such significantly reduced compliance and also ventilation and perfusion?
Which one of those is the answer to the question?
You potentially have some. You could potentially have some kind of West Zone 1 areas where your
hey Dan, I'm going to stop you there. So one of the things you said is the important thing. So you said a bunch of things: ventilation, perfusion, compliance. I think you said, but I think one of those is the main factor here. Which one do you think? The fact that there's, in spite of being such high PO2 readings, why is there only a little bit of oxygen content or uptake, for the body occurring at the apex? One of those 3 things.
I guess they're all contributing. Is it the compliance?
No, it's as in, because I'm already giving you the fact that there's lots of oxygen there. So regardless of what ventilation and compliance is occurring, you've got a PO2 reading that's super high. It's 132 at the apex in this example. So then the other factor here is perfusion. That it's the fact that you're not having actually that much blood flow. Like if you look at these numbers here for perfusion 0.07 versus 1.29, that's a massive difference, right? So no matter how, it's almost like I could say, hey Dan, your lungs have a PO2 of 760 throughout the whole lung. Impossible, but let's say you do. But then, and you think, oh, that's great. And then in the next sentence I say, but you're getting like 0.001 mils per minute of flow. So now that 760 means nothing because you're just getting no oxygen. There's not enough hemoglobin there to actually carry anything. So it's virtually pointless.
Yeah, that makes sense.
Yeah, that makes sense. What happens with exercise?
So with exercise, there is increased cardiac output, and there is recruitment and distension of pulmonary capillaries. The minute ventilation also increases.
And those are all true, but now to answer the question, so get to the answer now. What happens in this context? There's minimal uptake of oxygen at the apex. What happens to that with exercise? Everything you're saying is right.
Yeah, so because of those two factors, the VQ, there's improved VQ matching across the lung, and this includes the apex due to the increase in cardiac output.
Good. And what happens to the O2 uptake in that context then?
So O2 uptake is increased.
Exactly. Now, I think you knew that answer, and just as a matter of technique, I feel like you probably knew the answer is, well, there's much more oxygen uptake. This is because of increased cardiac output causes increased recruitment and distension and better VQ matching. So when I'm thinking about giving the examiners confidence in what you're answering, you're pretty much saying the answer that they're asking. Like when you're in high school and they say, hey, when you want to answer a question, you repeat the thing. Why is there minimal oxygen? What happens to oxygen uptake with exercise? There's increased oxygen uptake with exercise would be the answer. So you know that you're answering the question, but all your facts around that were absolutely right. Increased oxygen uptake. What is the ultimate implication of this VQ inequality? And that's just a statement out of West that they talk about the fact that the lung will never have the perfect amount of oxygenated blood occurring because of VQ mismatch. Everything's not ideal. Therefore, you'll never get to this optimal level of oxygen delivery that would happen if there was perfect VQ matching. Why is there a depression arterial PO2 by VQ matching? And that was the answer being venous admixture. Next person along. George, can you explain this graph to me? And George, when you're answering that, I want you to just say true statements if just to give facts to the examiner, even the most basic facts.
Yeah. Okay. Well, so this graph has VQ ratios on the x-axis and the liters per minute of ventilation or blood flow on the y-axis, and there are essentially two graphs overlapped on each other, one demonstrating the perfusion and one demonstrating the ventilation. And toward the left, there is a VQ ratio of 0, indicating shunt, and essentially on the y-axis shows the amount of that, and on the right, the dead space. And in this example, most of the perfusion and ventilation flow rates are clustered around a ventilation perfusion ratio of 1, with more units having blood flow that is kind of slightly lower, and hence causing a average VQ ratio is probably just below 1. And it would represent the situation in an upright patient with healthy lungs and healthy cardiac output.
And George, with your answer, I felt again like you were saying a lot of information, you were saying a lot of repeated information, which is fine. And I want you to try and narrow it down to just get it as brief as possible. this shows VQ ratios in logarithmic fashion on the x-axis, ventilation or blood flow in liters per minute on the y-axis. And this shows, I've actually got a bit of a cheat here, the fact that you're showing this really, like this is a normal subject, this is what happens in normal lungs where you have overall ventilation perfusion a bit less than 1, but they're all very tightly, what this graph is trying to show, which now you know, is that there's very narrow dispersion. Like there's just, there's absence in the healthy lung of really poor segments. So I think that that's what this is showing. This is showing that there's really nothing in the extremes. They're all kind of clustered with narrow, there's very little standard deviation here. Like it's all clustered very much around this one number. Understanding that it is a logarithmic scale, so there is a bit going on here. But I think that's the point of this graph. What does a sick lung look like? So next person along. Hey Mason, what happens in sick lungs?
So I guess it would depend on the nature of the pathology, but generally patients with different pulmonary pathologies have a wider spread of VQ ratios.
Yep.
For example, in conditions like emphysema, where you can have destruction of alveoli, you can have reduction in blood flow and a larger amount of ventilation, so you have areas of increased VQ matching, as opposed to other pathologies where you may have increased perfusion for inadequate ventilation, such as is seen in the obstructive nature, still also in COPD, such that you would contribute to low VQ areas and VQ and venous admixture.
Yeah, sounds good. Describe for me what's going on here. And yeah,
sure. So this is a different patient, which compared to our last graph shows a different dispersion of VQ ratios. So importantly, they have some areas near the left-hand side of the graph where they have increased blood flow relative to the amount of ventilation, contributing to a low VQ area, which would cause venous admixture and potentially arterial hypoxemia. They also do have some areas, around about, the 5 point on this graph where they've got increased ventilation relative to their perfusion, which would equate to relative dead space.
Yeah, that sounds good. What does the graph show? And I was just going through, I think this is in Miller's. Have you seen this graph, Mason?
I've not seen it from Miller's. I think I've probably seen similar things elsewhere.
Yeah, I'm sure it's in Google somewhere. Look, and I thought, okay, so if you describe that one graph, that's probably the first level of it. It's pretty easy. You can observe the fact that normal lungs have a very narrow dispersion and everything's very well matched. And then you get to the point where, hey, now I've got a problematic lung, asthma, COPD, pneumonia, and these are just examples of it. But I can imagine that this is what the next stage of the exam question, if he was a Viva, would get to. Or maybe you've got to, show VQ mismatching on the short answer question. You might draw this, graph A, and then just draw one of these other graphs, just showing, what an asthmatic lung would look like.
Can I just ask, for the COPD graph here, I always imagined that it might actually look a bit like a combination of that and the asthma graph, given that you have areas of effectively bronchoconstriction, but then other areas of alveolar destruction from the emphysema side of the picture.
Yeah, and with these graphs, I don't know that this is like typical. Obviously, COPD is a spectrum of pathologies from the bronchitis type picture to the emphysematous type picture. So, I think you can have a lot of different pathologies depending on what the destruction is. Like if you imagine COPD, some people will have alveolar destruction and emphysema and those problems, and others will have the asthmatic type problem. So I think that you're right that this could be a whole bunch of things. I think asthma is probably more uniform, but yeah, I don't know if these graphs are pretty much an average of many healthy lungs, or they've just done this as an example of one subject, but to show that there's VQ mismatching. Good.
Can I ask a quick question on the previous slide?
Yeah.
So
this one? Or
no,
this?
so the one where you had the 4 up, the Miller's one.
Oh, 4, yeah. There we go.
That makes, yeah. So in West, it has the 2 examples of normal and I believe COPD, which are there. Probably it might be a dumb question, but I just haven't seen the asthma version from Miller's before. Why is the perfusion in terms of litres per minute much reduced relative to the ventilation?
Why is the perfusion reduced? As in, when
So
we're talking
it
about...
only hits 0.6 litres per minute, whereas the ventilation hits 1 litre per minute in terms of their peaks.
These are all, this graph is showing...
Have I misinterpreted the graph there?
Yeah, look, I could be wrong about this. When I look at this graph, I can't actually show what the total amount of flow is. Because, for example, the cardiac output of, let's say you get one healthy patient with a cardiac output of 5 litres per minute, and the patient then with asthma with the same cardiac output of 5 litres per minute. This will show the distribution of that 5 litres per minute across the lung units. Just have a read of this, because this is describing that figure. A, normal lungs, mode centered around VQ ratio of 1. This results in near optimal oxygenation of blood and CO2 removal. B was asthma. There's a broader distribution, and with some regions being ventilated well in excess of perfusion, and with another mode of low VQ centered around a ratio of 0.1. This mode can be explained by collateral ventilation. So collateral ventilation maintaining gas exchange in alveoli behind occluded airways. There's no shunt seen in asthma, which I think potentially contradicts what the previous graph had. In COPD-C, the pattern is similar to asthma, but with an additional high VQ mode that adds to dead space such as ventilation. Shunt is not present, and the pattern of VQ distribution is not associated with significant hypoxemia. In lobar pneumonia, the major finding is pure shunt, consolidated, perfused, and poorly ventilated lobe. There's only minor widening of the VQ distribution.